Welcome to the 7th class of our ECG course. In today's session, we will be exploring ventricular conduction disturbances, specifically focusing on bundle branch blocks and related abnormalities. Whether you're a medical professional seeking to deepen your understanding, or simply interested in learning more about ECGs, we promise an informative and engaging discussion. So, let's get started. Do you remember how the heart works? Let me explain it to you in simple terms. The heart has two upper chambers called the atria, and two lower chambers called the ventricles. When the heart beats, an electrical signal travels from the atria to the ventricles through a pathway called the atrioventricular, or AV node, and his Purkinje system. The signal first stimulates the left side of the ventricular septum, and then spreads to the rest of the ventricles through the left and right bundle branches. This whole process of ventricular depolarization usually takes less than 0.1 second, or 100 milliseconds in healthy adults. And the normal QRS complex, which is measured by computer from all 12 leads, is less than or equal to 110 milliseconds, or about 2.5 small boxes on the ECG paper by eye. However, if anything interferes with this normal process, like a block or delay in the bundle branch system, it can make the QRS complex wider or change its direction. This class focuses on how bundle branch blocks or delays affect the QRS complex and STT waves on an ECG. A general principle to keep in mind when predicting what the ECG will show with a bundle branch or fascicular block is that the last, and usually dominant, component of the QRS vector will be shifted in the direction of the last part of the ventricles to be depolarized. This means that the major QRS vector shifts toward the regions of the heart that are most delayed in being stimulated. Let's talk about right bundle branch block, or RBBB for short. When the right bundle branch is cut or conduction is slowed down, it causes a delay in right ventricular stimulation, which leads to a widened QRS complex. Normally, the interventricular septum is the first part of the ventricles to be depolarized, but this shouldn't be affected by RBBB because the left bundle still stimulates it. The second phase is the simultaneous depolarization of the left and right ventricles, which also isn't affected by RBBB because the left ventricle is electrically predominant. The third phase is delayed right ventricular depolarization, which produces a second R wave in lead V1 and a broad S wave in lead V6. To diagnose RBBB, you need to look at leads V1 and V6 in particular, as they show the characteristic pattern of an RSR complex with a broad R wave in V1 and a QRS pattern with a wide S wave in V6. You might also notice that T waves in the right chest leads are inverted, which is a characteristic finding with RBBB. RBBB can be split into two forms, complete and incomplete, based on the width of the QRS complex. Complete RBBB is when the QRS complex lasts 0.12 seconds or longer and has an RSR pattern in lead V1 and a QRS pattern in lead V6. In contrast, incomplete RBBB has the same QRS patterns, but its duration is between 0.10 and 0.12 seconds. RBBB has clinical significance and can be caused by various factors. Some people have it without any underlying heart disorder, making it an isolated ECG abnormality. However, RBBB can also be associated with organic heart disease, including conditions that affect the right side of the heart, such as pulmonary disease, valvular lesions, cardiomyopathies, and coronary disease. In older people, it may be related to degenerative changes in the conduction system or occur after cardiac surgery. Pulmonary embolism can also cause RBBB by producing acute right-sided heart overload. RBBB does not require specific treatment by itself, and it can be permanent or transient. Sometimes it only appears when the heart rate exceeds a certain critical value, and it's called rate-related RBBB, which is not a diagnostic finding. However, in patients with acute anterior wall infarction, a new RBBB may indicate an increased risk of complete heart block, especially when associated with left anterior or posterior fascicular block and a prolonged PR interval. A new RBBB with acute ST segment elevation anterior myocardial infarction is also a marker of more extensive myocardial damage, often associated with heart failure or even cardiogenic shock. In some cases, a pattern resembling RBBB, known as pseudo-RBBB, is characteristic of the Brugada pattern and may be associated with an increased risk of ventricular tachyarrhythmias. It's worth noting that an RSR pattern with a narrow QRS duration of 100 milliseconds or less and a very small, up to 2 mm terminal R wave in V1 and V2, is a common normal variant, and should not be mistaken for an incomplete right ventricular branch block. Let's talk about left bundle branch block, or LBBB. It's another condition that affects the QRS complex, just like right bundle branch block, but in a different way. RBBB mainly affects the terminal phase of ventricular activation, while left bundle branch block affects the early phase. Normally, the left bundle stimulates the left side of the septum in the first phase of ventricular stimulation. However, with left bundle branch block, this normal pattern is blocked, causing the septum to depolarize from right to left instead of left to right. As a result, there is a loss of the normal septal R wave in lead V1 and the normal septal Q wave in lead V6, and the QRS complex becomes abnormally wide. Lead V6 shows a wide, entirely positive R wave, while the right chest leads record a negative QRS or QS complex. This is because the left ventricle is still electrically predominant with left bundle branch block, producing greater voltages than the right ventricle. T-wave inversions also occur with left bundle branch block, specifically in the leads with tall R waves, such as the left precordial leads. However, T-wave inversions in the right precordial leads could indicate a primary abnormality like ischemia. To diagnose complete left bundle branch block pattern, simply inspect leads V1 and V6. Lead V1 usually shows a wide, entirely negative QS complex, while lead V6 shows a wide, tall R wave without a Q wave. If you're having trouble differentiating left and right bundle branch block patterns, don't worry. It's not uncommon to see wide QRS complexes that don't fit either pattern. And this is called intraventricular delay. So when it comes to the clinical significance of left bundle branch block, it's usually a sign of organic heart disease, unlike right bundle branch block, which can sometimes occur without evident cardiac disease. There are various underlying factors that can cause LBBB, such as long-standing hypertensive heart disease, valvular lesions, like calcification of the mitral annulus, aortic stenosis, or aortic regurgitation, different types of cardiomyopathy, or even degenerative changes in the conduction system, especially in older patients. Sometimes there can be more than one contributing factor, like a combination of hypertension and coronary artery disease. While rare, some individuals may have an LBBB pattern without any evidence of organic heart disease. Echocardiograms can help identify abnormal ventricular activation patterns and other findings like valvular abnormalities, left ventricular hypertrophy, and diffuse wall motion disorders due to cardiomyopathy. LBBB can be permanent or transient and may only appear when the heart rate exceeds a certain critical value or decelerates below a certain critical value. Finally, LBBB can not only indicate major underlying cardiac disease, but the loss of ventricular synchrony induced by this conduction abnormality can also worsen cardiac function, especially in those with advanced heart disease. There is a treatment option called biventricular pacemaker therapy that can resynchronize ventricular contraction in patients with LBBB and heart failure, which will be covered in upcoming classes. When a YQRS pattern similar to bundle branch blocks appears on an ECG, it might not always be a true BBB. Here are some other situations that can mimic BBB. Pacemaker rhythms. Sometimes, pacemaker placement can make the ventricles activate in a way that looks like BBB on the ECG. For example, right ventricular pacing can mimic LBBB because the ventricles are activated from the electrode positioned in the right ventricular apex, close to the RBB where ventricular activation in the LBBB starts. Biventricular pacing can also resemble RBBB due to the left ventricular lead activating the heart from back to front toward lead V1, producing R wave in V1 similar to RBBB. Left ventricular hypertrophy. When the left ventricle is dilated or thickened, it can cause a delay in activation that prolongs the QRS duration, making it look like BBB. This pattern can be very similar to LBBB, including increased QRS voltage and secondary T-wave discordance. However, unlike LBBB, left ventricular hypertrophy is characterized by a prolonged intrinsicoid deflection, which is the time from the QRS onset to the peak of the R wave in leads V5 V6 of over 60 mSec, or 1.5 small boxes. Often, left ventricular hypertrophy pattern progresses to incomplete, and then to complete LBBB. Ventricular pre-excitation, or Wolff-Parkinson-White syndrome. This condition can create ECG patterns that look like BBB. Left ventricular pre-excitation produces a positive R wave in lead V1 because RV is activated last, whereas right ventricular pre-excitation creates deep S waves in lead V1, similar to that seen in LBBB, because the right ventricle is activated first. The clue to the presence of pre-excitation is a short PR interval and a very slow inscription of the initial part of the QRS, which is called delta wave. Other situations that can mimic BBB are ventricular arrhythmias, especially at slower rates. They can also look very similar to bundle branch blocks. Let's talk about fascicular blocks or hemiblocks, which is a slightly more complex but important topic. So far, we have talked about the left bundle branch system as if it were a single pathway. But actually, this system has been known for many years to be subdivided into an anterior fascicle and a posterior fascicle. The right bundle branch, in contrast, is a single pathway and consists of just one main fascicle or bundle. However, the branches and fascicles themselves are more like a ramifying fan than single pathways. It is possible that a block can occur at any single point or at multiple points in this trifascicular system. As we have seen previously in the ECG pattern with RBBB, the pattern of LBBB can occur in one of two ways: by a block in the left main bundle before it divides, or by blocks in both subdivisions, anterior and posterior fascicles. If a block occurs in just the anterior or just the posterior fascicle of the left bundle, we call it a hemiblock or fascicular block. The diagnosis of a fascicular block is made primarily from the mean QRS axis in the extremity or frontal plane leads. Somewhat surprisingly, a hemiblock, unlike a full LBBB or RBBB, does not widen the QRS complex markedly. Instead, it shifts the QRS axis. Left anterior fascicular block, or LFB, results in marked left axis deviation of about 45 degrees or more negative, whereas left posterior fascicular block, or LPFB, produces marked right axis deviation of about plus 120 degrees or more positive. Isolated LAFB is diagnosed by finding a mean QRS axis of minus 45 degrees or more, and a QRS width of less than 0.12 sec. In general, this finding is a very common, nonspecific abnormality that may be seen with hypertension, aortic valve disease, coronary disease, and aging, and sometimes without an identifiable cause. On the other hand, isolated LPFB is diagnosed by finding a mean QRS axis of plus 120 degrees or more positive, with a QRS width of less than 0.12 sec. Usually an RS complex is seen in lead D1, and a QR complex is seen in leads D2, D3, and AVF. However, the diagnosis of LPFB can be considered only after other, more common causes of right axis deviation have been excluded. Bifascicular block indicates blockage of any two of the three fascicles. For example, RBBB with LFB produces an RBBB pattern with marked left axis deviation. Thank you for investing your time in learning with us today. If you found this course valuable, we kindly request your support. Please share this video with your colleagues, subscribe to our channel, and give us a positive rating. Additionally, if possible, please consider donating any amount you can using the link provided in the video description below. Your support will enable us to continue providing free, high-quality education to anyone who wants to learn. Before we conclude, we would like to inform you that our upcoming class will cover myocardial infarction and ischemia, ST segment elevation, and Q-wave syndromes. This is a crucial topic for understanding ECG interpretation, and we're thrilled to delve deeper into it with you. Don't forget to subscribe to our channel and hit the notification bell to stay updated on our latest lessons. Once again, thank you for joining us today, and we look forward to having you in our next 100% online and free ECG course.